our talk today, hold on just a second. Our talk today is about Colorectal Cancer Awareness Month. March is Colon Cancer Awareness Month, so it's really important for us to just kind of get the word out that colon cancer really is preventable, really through colon cancer screening. So I'm going to kind of keep this pretty light. I really want this to be more informational for you, and then we'll open it up to questions at the end. I'm happy to try to answer your questions if I can. I am a gastroenterologist. I perform colonoscopies. That's all I do. I do screening colonoscopies at UVA. I am the lead for the cancer centers, the comprehensive cancer centers, colorectal cancer screening program. And I also co-chair our Virginia Colorectal Cancer Roundtable. So I don't know if any of you know about that. That's a new group, and we are trying to improve colon cancer screening across our great state. So I'm going to start with GI 101 so that we're all on the same page. So we all know kind of what the colon is. The colon is the large intestine, right? It is about 5 feet in length. When we talk about the colon, the function of the colon really is to store the stool, but it also is really important in absorbing water from the GI tract. So remember that we eat food, goes into the stomach, it all gets absorbed in that 23 feet of small intestine. A lot of enzymes get mixed up into it. And so by the time the stool gets into the small intestine and gets into the first part of the colon, which is the cecum over there on the left, the stool is really pretty liquid. And so from the time it goes from the right side of the colon, from the cecum through the ascending, through the transverse, all the way down to the sigmoid, it takes in most people about 24, sometimes 48 hours, sometimes a little bit longer in other people. But what has to happen in that time frame is that the water from the stool, which is about 1.5 liters in the right side of the colon, has to be all absorbed so that we don't lose all that fluid, that important fluid. And so the stool becomes more of a formed mass by the time it gets to the left side of the colon, and then it's stored there for a couple of days or a day or so. So what happens is that the transit time in the right colon is pretty fast. So stool goes through that right side of the colon pretty quickly. But by the time it gets to the left side of the colon, remember, because all this, the water is absorbed, the stool on the left side of the colon tends to be more concentrated, and also it's going to have more contact time with the mucosa because it's hanging around there for a little while. So that's the colon. The last part of the colon, the last 6 inches, is the rectum. So that's colorectal cancer, is a cancer that happens in that large intestine and the rectum. So disclaimer here, we're going to be talking about poop. We're going to be talking about blood. We're going to be talking about bowel preps. So if any of you guys get queasy, you know, I might want to step away now because we're going to be talking a lot about that during this talk today. All right, I wanted to bring a slide that shows you a little bit about the phases of colon cancer. You know, colon cancer is the second most common colon cancer in the United States, and it's super, super common. I mean, I think all of you must know somebody who have had colon cancer. And when we look even in amongst the famous people who have cancer, you recognize a lot of the faces on this screen, right? Chadwick Boseman had his colon cancer. He was diagnosed at age 30, in his 30s, and he died at age 43. Second is Don McEachin. He was a U.S. representative for Virginia in our 4th district, and he died last year from complications from therapy from colorectal cancer. Kirstie Alley died last year from colon cancer, but you see things like Ruth Bader Ginsburg, Charles Schultz, you know, the Queen Mother. Colon cancer has touched a lot of people, and it is a cancer that is really important for us to learn about because it can be preventable if we take the steps to get screened. So let's do a little bit of discussion about colon cancer facts. So about 1 in every 24 women, 1 in every 22 men will be diagnosed with colon cancer in their lifetime. And that's frankly too many people. It's the 3rd most common cause of cancer death in men and women. And it's sad because in the United States, we're going to see over 150,000 people are going to be diagnosed with this disease, and over 50,000 people in this country just this year alone are going to die from colon cancer. You may think that colon cancer screening is expensive. You know, getting a colonoscopy is expensive, but look how expensive it is if you get colon cancer. To actually get the diagnosis costs over $100,000. That's very, very expensive diagnosis. And more than half of the cases And more than half of the deaths from colon cancer are really thought to be due to things that we do in our own lifestyle. Things like smoking, unhealthy diets. So we talk a little bit about alcohol consumption is huge, particularly among women. I don't think people realize that women is a big risk factor. Alcohol is a big risk factor for women for colon cancer. Meat in our diet, high fat in our diet. I'll talk to you a little bit more, but sugary sweet drinks, sugary sweet beverages are a big changer of the microbiome. Physical inactivity and excess body weight are also increased risk factors. So when we look at the state of Virginia here, you can see that colon cancer rates in the state are really different based on the different counties that we have. And it's probably a lot due to the fact that you can see that the blue is the lowest risk of cancer in our state, and the red is the highest. So there's definitely hotspots in different parts of our state. Those hotspots are related somewhat to rurality, probably a lot due to access to medical care. Poverty plays a big role, and also access to good food, right? I mean, we know that there's definitely food deserts around our state that people don't have access to good quality food. So it's really important that we at the Virginia Colorectal Cancer Roundtable are focused particularly on these hotspots in rural Virginia, Southwest Virginia, and also on that eastern shore. All right, so what's really important, this comes from our my GI Society, the ASGE, which is the American Society of Gastrointestinal Endoscopy, to point out is that colon cancer is preventable, it's treatable, and it's beatable. So how is colon cancer preventable? It's really preventable really only by colorectal cancer screening. And so that's what the majority of my talk today is going to be focused on. This is a busy slide, but it's important for me to remind you that almost all colon cancers begin as polyps, right? So polyps start in the colon as small little tiny growths, and as they grow bigger and bigger, they actually can change and grow into a colon cancer. So the top left is a picture of a polyp that we're kind of used to seeing, what we expect that we think that we see and what a polyp should look like, either kind of a little hill or like a little mushroom. These polyps are called adenomas. And these polyps are have one sort of genetic sequence that they go through. It's called the adenoma to carcinoma sequence, where as a polyp starts and it grows over time, bigger and bigger, it goes through a number of genetic mutations, and those mutations take time to ultimately develop into colon cancer. But on the bottom right, you see a very different kind of polyp. And this is a polyp that it's always been there, but we just hadn't been able to see until our scopes got to be so much better. So people used to have colonoscopies, and then they would get colon cancers later. And it's because our scopes weren't good enough to be able to see these very, very subtle polyps. So these very flat polyps are called sessile serrated polyps. So in the left side of that picture on the bottom is what a sessile serrated polyp looks like with high definition white light endoscopy that we have now. And then if we put blue dye into the colon lumen, or now we actually have electronic dyes, so we can actually use blue light to actually see the margins of that polyp so much better. These sessile serrated polyps have a completely different genetic pathway to cancer than the adenomas do at the top, but still it takes a long time. There are a number of different genetic changes that happen, and they result in the same thing, a colon cancer. So here's what we see in endoscopy. I just wanted to show you the endoscopic pictures. So the left is a normal colon, should have good blood vessels. It should be shiny and smooth mucosa with lots of blood vessels and a clear opening, right? You think of the colon as having that pathway. The rings around the colon that you're seeing are really just that circular smooth muscle that helps to propel the stool from the gum to the bum, right? To help it get out to be able to pass. The polyps are here in the middle, are our adenomas at the top, and our sessile serrated polyp in the center. And then ultimately you can see as they grow and they get bigger and they undergo a number of those genetic changes, they develop into that colon cancer, which can block the colon. That progression from polyp to colon cancer, again, takes a long time because it needs a number of these genetic changes to happen. So in an average risk person, it takes about 10 years for that, 10 plus years, 10 to 15 years for that progression to happen. Now, remember, there's a number of genetic changes that happen in that sequence. So if somebody has a genetic predisposition to colon cancer, something maybe called Lynch syndrome or familial polyposis, what happens is that they start out already having one of those genetic mutations. So they start out already being a little bit further to the right. And so it may take somebody with a genetic syndrome a lot shorter time to develop colon cancer, maybe only 1 year or 3 years to develop colon cancer in somebody with that high risk population. So I'm going to change gears a little bit and talk about colon cancer screening, because we talk a lot about colon cancer screening, but does colon cancer screening really work? How effective is it? You know, I think it's really important to point out that when we're talking about other screenings, prostate cancer screening, lung cancer screening, cervical cancer screening, breast cancer screening, having mammograms, all of those tests are looking for cancer, right? You go to a mammogram and they're going to find cancer. The thing about colon cancer screening is we rarely, especially a screening colonoscopy, we rarely see colon cancer at screening colonoscopy. But what we can find, and what I tell my patients, is that we often find colon polyps. Colon polyps can be present in as many as 40 to 50%, 40 to 60% of Americans. And so polyps are common. And if you come and have your colonoscopy and we can take that polyp out, I can prevent you from developing colorectal cancer. So how effective is colon cancer screening? Here's a good slide. If you look at the top 3 bars here, you can see that's the incidence or the rate of colon cancer in men and women. And the bottom axis is just time from the 1920s all the way to 2020. And those bottom 3 lines are death rates in colon cancer. So you can see that probably from the when we started in the 1960s, looking at colon cancer incidence to the 1990s, we saw kind of a little bit of a drop in colon cancer rates. And that thought was probably due to the fact that we decreased smoking, had better lifestyle, had better access to good food. But really starting from the 90s, where that green line is, we see a real precipitous drop in colon cancer rates and in colon cancer deaths. And this drop in colon cancer rates is really largely attributable to colorectal cancer screening. So we started in the 1990s doing colon cancer screenings, and then we started doing more colonoscopies, Medicare approved colonoscopy in 2001. And so that's when more Medicare eligible patients were able to have colonoscopies, and we saw that real decline in colon cancer rates. So if you look in Virginia here, the rates in Virginia also decreased significantly. We have that drop as well, but we had a much bigger drop in Virginia beginning in 2001. And that's really thankfully due to our late state senator, Emily Kirk. So this is Katie Kirk's sister, and she's the person who our cancer center is named for. Emily Kirk in her own right was a superstar. Because her brother-in-law, Jay Monahan, was diagnosed with colon cancer in his 40s, she championed this legislation, making sure that Virginia was the first state in our country to make sure that insurers would pay for colorectal cancer screening. That happened in 2000, the legislation was actually adopted in 2001, but in 2000, she got that going. And you can see that when that legislation happened, colon cancer screening was paid for, and we saw a marked decline in colon cancer numbers because of her work, her really, really important work here in Virginia. So our goal is to get to about 80% of the population screened. So the American Cancer Society, the National Colorectal Cancer Roundtable has started this. They've championed this 80% in every community. We want 80% of all Americans between the ages of 45 and 75 to be screened for colorectal cancer. And at UVA, we have signed on to the pledge to get our screening goals to 80%. So how well are we doing in the United States and in Virginia? You can see that in the United States, only about 70%, 69% of adults, that's 62.3 million adults, have been screened for colon cancer. But if you look, it's very, very different across the country. The darker blue are the higher screening rates across the country. California is the lowest. It's hard to believe, but California is the lowest at 58.4%, and Maine is the highest at 79%. So nobody has reached that magic 80% number. In Virginia, we are at 73.6%. We're ranked 18th nationally. And, we Urbanians, we're competitive. We want to do better. And I think we can do better. It's important for us to do better so that we can save more people in our state and across our country from this disease that's really wholly preventable. What happens if we get to that 80%? So it used to be this 80% by 2018, but now it's 80% in every community. If we could achieve this goal of getting 80% screened, we could reduce the mortality from colon cancer by about a third, and we can avoid over 200,000 deaths in the next 20 years. So it's achievable. I'll tell you that Kaiser in California, because California had such a low rate of colon cancer screening, they really did a real big push to get colon cancer screening. They got 83% of their population screened for colon cancer. And when they did that, between 2000 and 2015, they saw 26% fewer cases of colon cancer and 52% fewer deaths from colon cancer. So screening does work, and screening does save lives, and it does make a difference. So pivoting again, so what are the options that you have for colon cancer screening tests? I know there's going to be lots of questions at the end here, but I hope I can get to the bottom of this so you really understand what tests are out there. And it's important to know that your doctor may push one test. You may have your own thoughts about a specific test that might be the best test. But while we're going through this, keep your mind open, because not everybody is going to pick colonoscopy, for instance. Not everybody can have a colonoscopy. Some people, it's just not the right time for them. They're busy, they're working mothers. They might be trying, 45-year-olds need to be screened right now, and they don't have time to take time off to do these kinds of things. So what are your options for colon cancer screening? These are them. So they are colonoscopy, which is taking a lighted camera and inserting it in and looking at the entire colon. Next are stool-based tests. So there's a couple of different stool-based tests. On the right up at the top is the fecal occult blood test. We don't use this anymore. It's really been largely replaced by what's called the fecal immunohistochemical test, or the FIT test. And it's really just a different kind of chemistry, but the FIT test looks for blood in the stool, and it looks for human blood in the stool. The fecal occult blood test looks for any blood. So the problem with the right test, the test on the right, the fecal occult blood test, was that if you ate raw meat or if you ate vegetables, certain kinds of vegetables, you could have false positives. Because this FIT test looks for human hemoglobin, it really is only looking for blood that's generated from us. There's the stool DNA test, or the Cologuard test. And then there's also a flexible sigmoidoscopy. That's only a screening of the lower third of the colon. Flexible sigmoidoscopy has really gone out of favor in the United States because it's only looking at about a third of the colon, so it's really not done very much. And we in the GI world like to equate a flexible sigmoidoscopy as doing a mammogram on one breast, right? You wouldn't do just part of your breast cancer screening by looking at one breast. It's important to look at the entire thing. So the other tests all look at the entire colon. And finally, the last test is a CT colonography. And a CT colonography is just that. It's a CAT scan, and we'll talk a little bit more about that. So there's different timings for these tests. If you have a colonoscopy as your screening and it's normal, you go every 10 years. For the FIT test, if it's normal, you have that done every year. For the stool DNA test or the Cologuard, we do that every 3 years if it's normal. And for a CT colonography, if it's normal, we do that every 5 years. So I'm going to spend the next couple of minutes really just talking about these tests, so you have a good idea about what these tests are, so that when people ask you, what should I do for my colon cancer screening, you can talk intelligently about what their options are. All right, so here, these are the stool-based tests. So the FIT test is an antibody test for human hemoglobin. And on the right is the Cologuard test. It not only tests for blood in the stool, but it also tests for DNA in the stool. So remember that in this cascade, from the start of a polyp to the formation of a cancer, these cells grow larger and larger over the time. As the polyps become larger, and even as they change into cancer, they can shed blood into the stool, and they also shed DNA and RNA and cells into the stool. So really, as they get bigger, they may shed more blood, and that blood may not be visible to your eye. So it's detecting microscopic amounts of blood. So the FIT test looks for blood. The the Cologuard test looks for some gene changes that are happening along that cascade. The nice thing about these stool-based tests is that they are simple, they're private, you do it at home and, in the privacy of your own home. They're non-invasive, so they have a really very, very low risk. The stool sample is just mailed to the lab. You get the kit, like the Cologuard, they mail the whole kit to your house. And then you collect the stool sample and you send it back to Exact Sciences. There's no dietary restrictions. For most people, there's no bowel prep. That's a lot of what a lot of people are scared about with doing a colonoscopy. So this kind of testing it can be very, very useful, particularly to people who are afraid of having a invasive test, afraid of the bowel prep, or may not have time to actually have a procedure for their colon cancer screening. All right, moving on. I'm going to talk a little bit about colon cancer CT colonography. The CT colonography is, sorry, my slides over here are not changing. CT colonography is a CT scan, uses both 2-dimensional and 3-dimensional imaging. You have to take a bowel prep for this, and really the reason for that is that it's just a little bit of oral contrast for the CT, and it tags the stool so that stool makes it so that the radiologist who's reading it doesn't mistake stool for a polyp if it's stuck to the colon. What they don't tell you about this test, though, is it also requires the colon to be insufflated. Your colon, if you think about it, when it's sitting there, parts of it are empty, and so it's flat like this. But in order for them to see really well, they need it to be blown up like a balloon. So in order to do a CT colonography, they actually place a rectal tube. They insert carbon dioxide into the colon. So it can be a little bit crampy sometimes. Sometimes they do air, but most of the time we're using carbon dioxide because that carbon dioxide can be expelled, and so it's easily removed. And then they take pictures with you on your back and on your side. It takes about 15 minutes. You drive yourself in, there's no sedation, and then you're out of there. A radiologist reads it, and you can see in those yellow arrows that they can see polyps if they're relatively large. The problem with a CT colonography, though, is remember I showed you those very flat polyps in the colon? So it's not going to do a very good job of seeing those very, very flat polyps. So CT colonography in some cases has gone out of favor for that reason. So if you have a positive FIT test, a positive Cologuard, or a positive CT colonography, all roads lead to colonoscopy, right? Those tests in themselves are not preventative. They're not diagnostic for a colon cancer either. You have to have a colonoscopy to be able to see the colon, see the lesion, and then remove the lesion if it's a polyp that can be removed. So let's talk a little bit next about colonoscopy. This is a test I think probably most of us are familiar with. It is a lighted camera that is inserted into the colon. Right now, our technology is so amazing with regard to that camera. So it used to be that I had to look in the scope like this, and nobody could see that screen. It was dark and like a tunnel. But now it's video. So I'm looking at a screen, and people always worry that I'm looking at their bums, but I'm looking at a screen up here. It's a really, really huge screen. It's HD quality, probably better than your TV. The cameras on the actual scopes are an incredible number of pixels as well. So they are able to pick up very tiny things. We can see polyps that are 1 millimeter in size. I mean, that's small. The problem with the colonoscopy, though, is it requires a prep. In order for me to be able to see those things, those flat lesions or those millimeter polyps, the colon has to be clean. So there's a variety of different kind of colonoscopy preps that are out there. And also, colonoscopy oftentimes requires sedation. So in the United States, we sedate the vast majority of patients for colon cancer screening. That's not the case in the world. If you look at other countries, a lot of other countries don't use sedation for colonoscopy, but we Americans, we like our sedation and we don't want pain with the colonoscopy, so I totally get it. But sedation requires oftentimes an anesthesiologist, maybe a little bit more expense, a day off of work. And then you have to have somebody else, another adult, to drive you, or your nice assistants through your Arlington neighborhood village to come in and drive you home. But you need somebody to drive you home, right? It's an invasive test, so it's going to be higher risk. The risks are there of perforation, poking a hole through the bowel, bleeding if we take a polyp off. some discomfort. So it's definitely a procedure that has a little bit more risk than some of the other tests that we talked about. So who gets which tests? Let's start at the bottom. If you have a higher risk for colorectal cancer, if you have a family history, somebody, and particularly somebody who is a first-degree relative. So if you have a parent or a sibling or a child who has colon cancer, or a parent or a sibling or a child who has advanced polyps, your risk is higher. We used to believe that just having a family history of colon polyps increased our risk, but that's not true anymore, because colon polyps, we now know, are super common. About 40 to 60% of people have colon polyps. So just having polyps alone doesn't necessarily increase your risk, but if somebody has an advanced polyp, that increases your risk. If you yourself have had colon cancer or advanced polyps, if you yourself have had inflammatory bowel disease, so Crohn's disease or ulcerative colitis, if you have a family genetic syndrome such as Lynch syndrome or familial polyposis, there's a number of family genetic syndromes that are linked to colon cancer, or if you've had prior radiation therapy to your abdomen or pelvis. So somebody who's had prostate cancer and had radiation, or somebody who's had cervical cancer and had radiation to the pelvis, or Hodgkin's lymphoma. All of these patients are at increased risk of colorectal cancer and should have colonoscopy. Everybody else, if you don't have any of these risk factors, you're between the ages of 45 and 75, you can have any of this gamut. You're considered average risk, and you can have any of these other colon cancer screening tests. So just wanted to show you how commonly are these tests used. So in the United States, if you look at that blue line at the top, the vast majority of insured individuals are getting screened with colonoscopy. The second most commonly used screening test is the FIT test. It's actually the black bar that's under the 25%, but you can see that it's still a much smaller number than are screened by colonoscopy. I told you a little bit, the orange bar is the fecal occult blood test. We don't use that so much anymore. It's been replaced by that FIT test. And Cologuard was actually approved in 2014. So we see that since 2014, there's been a slow and steady rise in Cologuard use. CT colonography and flexible sigmoidoscopy, because of those other things that we talked about earlier, are really rarely used anymore. We really don't see them. So FIT testing, colonoscopy, and and Cologuard, sorry, FIT testing, Cologuard, and colonoscopy are the three main colon cancer screening tests that are used most often in the United States now. So I get asked this question all the time. So which colon cancer screening test is best? I'm going to show you this, but I think it's important just to point out a lot of things. So when we look at the screening test, it depends on a lot of different things, right? If you look at what is the ability of a screening test to detect colon cancer, that's its sensitivity here. So sensitivity here, you might say, well, colonoscopy is the gold standard, right? It's the way that we actually can find colon cancer. So it's the sensitivity of colonoscopy is still not 100%. And so it's important to remind you that if you're having a colonoscopy, you need to make sure that the person who's doing your colonoscopy is somebody who does a quality colonoscopy. It's important for you to ask your gastroenterologist, what is your adenoma detection rate? How good are you at finding polyps? We have this as a national quality standard, and you should be able to find polyps in about the low level is 25% of your colonoscopies, first-time colonoscopies, but most of us have adenoma detection rates of about 40 to 50%. So colonoscopy is not 100%, but it's pretty darn close. If you look at the FIT test, you might think, oh, that 80% chance of finding a colon cancer is really, really low. But it's important to remind you that when we do tests for colon cancer screening with a FIT test, it's only looking at what is the chance of finding it at that one time. But remember, a FIT is done annually, and that these colon cancers or polyps grow over time pretty slowly. So if you do a FIT test this year and next year and the next year, over time, it reaches that of about doing a Cologuard, almost 92%. Cologuard is less sensitive than colonoscopy, but it's still very good, 92% chance of finding a colon cancer. What is specificity? Specificity it tells you a little bit about how good the test is if it's negative. So if a test is, if you have a Cologuard, say you have a FIT test and it's 96% chance of it being, if you have a negative test, you have a 96% chance of not having a colon cancer. So Cologuard's not so good at this. Its specificity is pretty low, meaning that if you get a positive Cologuard, it may not really be colon cancer. So there's a 13% chance if you have what we call false positives. So if you have a positive Cologuard test and you come in, you're really worried, right? You come in for a colonoscopy, you might not have anything. And the reason for that, why does Cologuard have such a high false positivity rate? It's because, remember, it's looking at DNA methylation. So it's looking at those DNA changes. And so what we see is that in Cologuard, there's a higher risk of having those false positives in patients who are older, so older than the age of about 65. And that's because in older people, as we age, our DNA automatically methylates. That's kind of what happens when we get senescence or aging of our cells. And so Cologuard is able to pick that up, but it comes a false positive. So it plays a role. So Cologuard may not be the best screening test for somebody who is older, say over the age of 65. We see less of that false positivity rate in people younger, between the ages of 45 and 55, for instance. Let's also look at cost. I think this is really, really important. You might think that these stool tests, the FIT and the Cologuard, are equal, but they're not. A Cologuard test is really pretty expensive, costs about between $500 and $700 to perform, whereas the FIT test probably costs about, it can be pennies, it can be, $8 to $20. So it's really very, very inexpensive to have FIT testing. So if budget is important to you, or if you're paying for part of your copay or deductible, you might think about these. Although the vast majority of colon cancer screenings are covered by insurance. I wanted to show you this though, because when major societies look at the effectiveness of a colon cancer screening test, they're looking at it based on population. So what I showed you last time was, what's my individual chance of having a colon cancer if I have one of these tests? But when the United States Preventive Services Task Force looks at how effective these cancers are, they're looking at it from a population standpoint. So they're looking at the millions of people who have colon cancer screening, how good are they at years of life gained. So we want these tests to be able to increase our lifespan, right, by having the tests. And if you look at a FIT test every year, a Cologuard every 3 years, a CT colonography every 5 years, or a colonoscopy every 10 years, those red dots, they're about the same. So they do about the same job. So that's why, if you look at the United States Preventive Services Task Force recommendations for colon cancer screening, all 4 of those tests are considered, including a FlexSig, are considered to be equivalent in our ability to do a good job to screen for colon cancer. But you have to take in so many of these other things, right? You have to weigh the risks and the benefits, the pros and the cons of each of these tests, right? Not only the at-home aspect of this, but whether or not they require a prep. I'm hoping, guys, that my institution is not going to do an update here, but if you lose me, I promise I'll be back. I'm not sure what's going on here.
Cindy, we can hear you and we can see your screen.
Okay, good. But you can probably see that there's an update happening that I can't get rid of either.
Can't see that.
Lots of things to think about when we're thinking about different pros and cons for different tests, right? So I'm going to move on. Okay, so what's really, really important is that when we're thinking about colorectal cancer screening, that there's shared decision-making that's happening. So your doctor, your nurse practitioner, your PA should discuss colon cancer screening options with you, and they should use shared decision-making. We want to decide which test is best for you based on its pros, its cons. What's its availability? If you're living in Alaska, you might not have access to a colonoscopy, and the patient preferences. Those all things should be incorporated into the decision, not just your doctor says you should only have one test or the other. Sorry. Good. So which screening test is best? It's the one that gets done and the one that gets done well. So we really just want to make sure that people get screened, not just pondering about what tests to do. All right, I'm going to take another pivot here because you probably have seen in the news recently that there has been an alarming increase in early onset colorectal cancer. So we're seeing colorectal cancer up about 50% in people between the ages of 45 to 55. And you saw in that earlier slide, Chadwick Boseman was diagnosed in his 30s. Jay Monahan was diagnosed at age 41. In the last decade here at UVA Health, we have seen so much cancer, colon cancer in young people. It's really devastating and heartbreaking. In the last year, amongst my I'm older, but amongst my younger colleagues in medicine, I've seen 4 colleagues that have been diagnosed with colon cancer under the age of 55. So it's definitely become more epidemic proportions. Now, caveat here, the vast majority of colon cancer is still in people over the age of 60, right? And we're seeing that over the age of 60, colon cancer rates are dropping because of screening. But what we're seeing, though, is between the ages of 45 to 55, those rates are actually doubling. All right, so here's the slide here that's really important for you, is just that there's an increase of colon cancer in Gen Xers and millennials. We used to see, if you look at that light on the bottom left, if you look at the colon cancer rates in people over the age of 50, they're dropping because of screening, but they're rising in people under the age of 50. This is an old slide. So in 2017, we used to see that the rate of colon cancer was about 1 out of every 10 people under the age of 55 was diagnosed with colon cancer, but now it's 1 out of every 5. It's doubled. What we're seeing about colon cancer in young people is that it tends to be more left-sided colon cancers, and it tends to be more rectal cancers. And so these patients, these people are presenting with symptoms, right? Rectal cancers in that lower part of the colon is more likely to present with bleeding, more likely to present with constipation, or even weight loss. What's the cause of early onset colon cancer? We really don't know. We know that colon cancer is found at a later stage in these younger people. We also know that colon cancer has a much poorer prognosis in people who are younger. About 30 to 40% of people will have a family history of colon cancer or genetic mutation, but in over 60% of early onset colon cancer, the cause is really unknown. It's thought, though, that the large portion of this is probably related to our gut microbiome. And if you think about it, a lot affects our gut microbiome. So obesity, our food intake, so our westernized diet, so higher fat, higher meat is going to change the features of our gut. In the United States, what we're focusing now on is sugary soft drinks, sugary sweet soft drinks and beverages. If you think about it, our children's group used to drink much more of these high energy, high fructose drinks than we ever did, and had a lot more the kinds of exposure to things like antibiotics. They also had more cesarean section births. So if you think of C-section births, they didn't expose a child to the mother's vaginal flora, which could affect their colon bacteria as well. So it's thought that the microbiome probably plays a pretty big role in early onset colon cancer, but we just don't know yet. And we're doing a lot of studies here at UVA. I think one of the really cool studies that are being done right now is I'm working with Lee, who is the chairman of our family practice group, and he is taking colon samples. So my patients come in for colonoscopy, and we take biopsies from different parts of the colon, and we're actually making microscopic little mini colons. They're called colon organoids. We take these colon organoids and we're exposing them to different things. So right now they're exposing them to sugary sweet and sugary sweet beverages, and seeing whether or not there's changes in the DNA methylation that is happening in different parts of the colon. So the right colon, the left colon, and the rectum. We're seeing whether or not there's DNA methylation changes, and that signals that change more towards cancer. So it's really exciting research that's happening. I think we're going to know a little bit more about that. So what are we doing to try to improve to try to reduce the rate of colon cancer in young people? So now you know that the vast majority of, oh no, please don't do this. The vast majority of people, if I sign out, guys, I might have to say sign out and goodbye, but I'll come back in a little bit. You guys talk amongst yourself and I'll try to come back. But we start colon cancer screening at age 50. Sorry, I should have done this from home. I really thought about doing this from home, but when I get to the university, we get sign outs just at any time. So I apologize. So we start colon cancer at age 45. But also, if somebody has symptoms, if you have blood in your stool, if you have change in your bathroom habits, you should have a colonoscopy, right? And this is no matter what age you are. If you're 25 years old now and you have blood in your stools, in the olden days, you used to say, oh, it's probably hemorrhoids. Don't worry about it. And people who are young tend to think, I have a little blood in my stool, it's going to go away. But what's horrible, and what we have seen here at UVA too, is somebody who's been told by their mother or their primary care provider that they just had hemorrhoids, not to worry about it. And months later, they come in.
Oh, she's gone. Wendy, you're muted.
Well, she knew something was going to happen.
That's colon cancer.
All right.
That is about screening, right? So that means that you have never had a polyp in your life, and that so it's presuming that people have had prior screenings in the past. The reason for that, why is that recommendation happening? It's happening because in the United States, the average American lifespan is 85 to 86, right? And so from this time of a polyp, start of a polyp to the formation of a cancer takes over a decade. A lot of people have a lot of medical issues between after the age of 75 as well, that may preclude them from having, say, surgery for colon cancer if it's found. So that's why that recommendation for 75 is there. It is not a recommendation, like you said, that's one size fits all. The United States Preventive Services Task Force says that screening should continue between the ages of 76 to 85 based on a discussion with your doctor or your provider, right? And really, if you're in Arlington, you've got a lot of older adults who are active and they still have a 10-year lifespan. That's really the thing that I tell my colleagues or my patients is if you have a 10-year lifespan, you should probably be okay to continue colon cancer screening. Now, that's screening, right? And the most benefit for screening in somebody over the age of 75 would probably be in somebody who has had who has never been screened ever before, right? So if you never ever had a screening and you come in at 76, yeah, you should be screened. And if you're healthy, because we're likely to find a polyp, we're likely to find something that we can take care of and prevent you from developing colon cancer. For a lot of Americans, though, you want to have screening because you think that it's going to be better, but you've already had 5 lifetime colonoscopies, right? So you have colonoscopies or 5 lifetime screenings and lots of screenings in that period of time. If you have that many screenings and you reach the age of 75 and you have nothing, you've never had a polyp, your risk of colon cancer in your lifetime is very low. There's a lot of data that shows if you have 2 unremarkable, meaning low risk polyps even, colonoscopies, 2 unremarkable colonoscopies in your lifetime, your risk of colon cancer in your lifetime is really pretty remote. So if you get to 75 and you don't have very much of anything, you've never had an advanced polyp in your life, then you could feel comfortable in knowing that your colon cancer is low.
You've had 4 or 5 colonoscopies, you've had 4 or 5 lifetime
Jean,
Yep.
Jean, you haven't muted yourself.
Sorry.
The other thing is that I think for people who have had a history of polyps, people who have a family history, or people who have colon cancer in their personal history, those people should keep going on screening as long as you have a 10-year lifespan ahead of you. And that's where I rely on my primary care colleagues to be able to say, yes, you have this much lifespan. So I'll tell you, a colleague of mine lives in Mesa, Arizona, And we talked about this. He does colonoscopies on 90-year-olds all the time. They're all in retirement communities and, they're coming in, they're healthy. But if you're in a different population, we may not see that. Do we see 50-year-olds who have, advanced breast cancer, for instance, who are getting chemotherapy and don't have 10 years to live? We stop screening those people too, because the benefits of screening don't help them, right? So I think it really depends upon your lifespan. Does that help?
Yeah. There was one question in the chat that was, why is there no risk for cancer in the small intestine?
Yeah, because if you think about it, the stool really doesn't go into, it has such quick transit time through the small intestine. So through the small intestine, it may take just a matter of hours for the stool to get through there. Also, there's no bacteria in the small intestine. Our small intestine is pretty sterile. So doesn't have the risk factors it does as the colon does. Plus, it would be really hard to screen. It's about 20 feet.
I know my question was stupid. I don't want to take your time, but the picture of the small and the large colon is always shown so much like that square box around the small one. And then you had some scans that sort of showed it more collapsed. I was just curious, how accurate is that diagram of making a rectangle?
Yeah, it is pretty accurate. So you come up the left side of your body because the colon is actually attached at a couple of points. It's attached to the spleen, which is in our left upper quadrant, and it's attached at the liver, which is in our right upper quadrant. So it is kind of held up there like an apron. So women tend to have longer colons. It's really because of pregnancy. And because pregnancy stretches out our transverse colon and our sigmoid colon. So women tend to have longer sigmoids. Our transverse, instead of it being an upside down U in men, in women, we tend to have an M. So it comes up, it goes down, it comes up, and it goes down. So gravity is not nice to women in a lot of ways.
Do you think the prep for colonoscopies is going to get better over time, just from the issue of how it tastes, et cetera?
It is better over time already from how it tastes, right? I mean, when we talk about colon cancer preps in the past, it only used to be about doing the gallon jug that's out there. And the gallon jug has gotten a little bit better tasting as well. It's a lot of volume, but if you think about it, that volume is super, super necessary because it helps to wash stuff out of the colon. I will tell you that if you can tolerate that gallon prep, it is still by far and above the best prep that's out there. It is the one that cleans the colon sparkling clean and gets the colon really, really clean for me to be able to see. So I actually use that prep a fair amount still, especially in people who are constipated. And as we get older, we have a higher risk of being constipated. So it's useful, but there's a lot of different preps that are out there. So you probably heard of something that's called Suprep, Clempic. Those preps are smaller volume that you can take. They still taste nasty, but they you chug a little bit of a glass, then you follow it with glasses of water. There's also pills. There's a pill prep that's called Sutab, and it's 24 pills. They're pretty big pills. You take 12 of them with a bunch of water the night before and 12 the day of the procedure. What's super, super important is that what we've learned is that we need to break that colon prep in half. You can't do all of your prep the night before as you used to do in the past, because you need to break it in half. So you do half of it the night before and half of it the day of, usually within 4 to 6 hours of your colonoscopy. Because what happens, what we found is that if you take it all the night before, your colon doesn't have a lot of stool in it, but the bile from your ileum actually coats the entire right side of the colon and that cecum. And so all those flat polyps become really, really hard to see because your entire right colon is covered in mucus and bile. So we want the colon to be crystal clear. So splitting that prep, taking part the night before and part the day of is really important. Oh, but I will tell you what's exciting is some people are just developing food-based preps. So they're actually making these bars. I don't believe these are going to work, and I don't think I'll ever use them, but they're making bars and they're making these smoothie kind of things that you drink so that you can kind of mix it up a little bit. So you eat a little bar and it's got prep in it. You eat a little bit of a smoothie thing and it's got prep in it, but you have to still drink a lot of fluid to get things clear. Mm-hmm. Personally, I don't think that's really going to work out that well, but we'll see. They're in study. They're being studied. What stool symptoms cause concern? I think the biggest stool symptom that should cause concern is blood in your stools. Now, if you guys have already had a colonoscopy and you know you have hemorrhoids and you know you don't have anything out there, you've had a colonoscopy in the last 3 to 5 years and you know you have hemorrhoids and you have occasional bleeding, you don't have to have another colonoscopy. But particularly for these young people, your children, my children, who are young age, because rectal cancer and left-sided colon cancers are so much more prevalent in that age group, if they have rectal bleeding, even a small amount, even on one occasion, they should probably have a colonoscopy.
And hemorrhoids turn into cancer?
No, no. Hemorrhoids are just blood vessels. They happen, they just are from straining, no, not at all. No risk at all.
Cindy, I know that there's a last question in here, and it's sort of one that I had similarly, and it's more GI than cancer, so I apologize. But so now that you've talked and I understand better how the system works in terms of the large colon pulling moisture, water out of stool, when you have diarrhea, I assume that the water's not being pulled out. And is that, and what causes diarrhea, I guess is my question.
So it's either that the moisture is not being pulled out or there's excess moisture being put in. So like when somebody has traveler's diarrhea, you go to Mexico and you eat something really, really bad. What happens is that those bacteria cause your gut to secrete a lot of fluid. And so that excess fluid overburdens your colon's ability to absorb that water. So you have diarrhea. If you, there's a disease called microscopic colitis, where somebody has a normal looking colon, but they have a layer of collagen in their colon. It happens more commonly in women as we age, but it's what happens is that the layer of collagen that sits underneath the colon cells becomes thicker. So it inhibits our colon's ability to absorb that water. And so you're going to get diarrhea. So it can be either too much in or not enough being able to be sucked out.
Mm-hmm. Thank you.
Yeah.
Would you recommend the Cologuard test in between colonoscopies?
No, thank you for asking that question. Oh my gosh, thank you so much for asking that question. No, and don't do that. For one, you'll get billed for that 100%. So if you've had a colonoscopy in 5 years ago and it was completely normal and you do a Cologuard, your Medicare, your insurance company is going to know that you already had your screening. It was done and they paid for your colonoscopy, which was thousands of dollars every year. And if you go and you have a Cologuard, unfortunately, I work with that company very often, but they don't ask you whether or not you had a colonoscopy, which I think they should. So what's happening is people are getting that test, which is completely unnecessary because you've already had your screening done. You had a colonoscopy, it was normal 5 years ago. If you do the Cologuard, you'll get charged for it. You'll pay that $800 out of pocket because your insurance, Medicare is going to say, we're not covering it. Plus, it's not necessary. And what we've seen happen too is people will have that Cologuard done. So it's like a double whammy. You get the Cologuard, you're over 65, you have that higher risk of false positives because your DNA is methylating with aging already. The Cologuard is positive, it's a false positive. So you have to have another colonoscopy, right? You have to you have weeks of worry before your colonoscopy is scheduled, and then it's negative. So no, choose one or the other, if you're going to do a Cologuard, fine, do your Cologuard. That's what you can do. And you could switch it up. If you want to do a Cologuard and 3 years later, you want to do a colonoscopy, great. If you want to have a colonoscopy, and what I tell people this is if they're 45 and you have your colonoscopy and it's completely normal, you should think about having a Cologuard next time in 10 years, because it's a lot to do, right? To have a colonoscopy for a normal exam. And your likelihood, if you had a normal exam the first time, your likelihood of having something pretty unremarkable the second time is pretty low.
What
It's very
about
high.
somebody
Your chance of having
who's
something bad.
what about somebody who's known to be at high risk, like they had an abnormal colonoscopy?
No, right? You saw my slide. Who gets a Cologuard? Only average risk people. So if you've had a polyp, no, you go straight to colonoscopy every time. Now, the only caveat to that is if somebody says, I have a family history of colon cancer, but I absolutely refuse to have a colonoscopy, I won't do it. I will only get screened if I have a Cologuard. And if by God, the Cologuard is positive, then I'll have that colonoscopy. But that happens so rarely, right? Few and far between. Most people who have a higher risk of colon cancer in their family are going to want that colonoscopy, and they do that. Yeah.
How often do people not have polyps? I mean, it seems to me that it's fairly common, so I'm surprised that anyone would get to like 80 and never have had a polyp.
You're exactly right. That's what ends up happening. So you do Cologuard, and you will be ultimately positive, or fit, and you'll ultimately be positive. So, you know, the risk of polyps increases with age too. So a 45-year-old, small polyps, or what we call advanced polyps, maybe only in the 20 to 6, small polyps, maybe only 6%, sorry, about 20%. Advanced polyps, maybe only 6%, maybe very, very small. As we age, those numbers increase, right? Because we have more things on the outside too, right? We have a little more barnacles and things on our outside, same as the inside. So we see that risk of polyps increases as we age. Yeah.
Okay, well, I think
Cindy, Dr. Yoshida, we've taken a lot of your time.
No,
And you
I'm
have
sorry.
been-
I apologize so much for.
No, don't. I mean, we were Dr. Internet to each other
Okay.
for that interim break. And I'm
right,
sure that
I'll-
we balanced out your entire educated conversation with all of the foolishness that we taught each other. No, we really appreciate you taking the time. As you can tell from the questions, it was incredibly valuable to all of us on the phone, all of us on Zoom, and we really, really appreciate it. We may invite you back to be an annual speaker because people
Happy to do that. All of you guys, March is Colon Cancer Awareness Month. Please spread the word, particularly to your children, that colon cancer screening definitely works. I really, really want to thank you all for your good work.
Well-
It just warms my heart for all the things that you do for other people. Thank you so much. Thanks for having me. Take care.
Thank you so much. Thank you very
Bye.
much. Bye-bye. Caroline, great.